Welcome to Vienna, where we are at the European Cancer Care Conference for 2015. This is one of the largest cancer conferences in Europe and is a truly international event, looking at the spectrum of cancers in developed countries and in less developed countries across the world. My name is Noel Clarke. I'm a urologist and a urological oncologist from Manchester, the Christie Hospital. And I'm joined by my friend and colleague, Bertrand Tombal, who's Professor of Urology at the Louvain University Hospital in Brussels. We're going to talk about a couple of specific abstracts and presentations, which have been a feature of the first couple of days of this meeting, and they pertain to prostate cancer and its management. This is a big topic, lots of important data. New data has been read and released at this meeting. And I'm going to start with an abstract which was an important abstract in my view. And Bertrand, you reviewed this abstract as one of the special reviewers for the session in prostate cancer yesterday, that's Saturday, on TAC385. Now this is an oral GnRH antagonist and is currently being tested, having come through its phase 1 and early phase 2 data, and Neil Shaw, one of the leading urological oncologists in the US, presented some data. Bertrand, just tell us briefly what you found.
So I may be biased because I'm a big fan of antagonists, because clearly we've been using hormone therapy, as you know, for forever. And very interestingly, the drug we've been using that are LHRH agonists, we can say they are pharmacologically aberrant, because before they suppress testosterone, they first elevated it transiently. And actually, you would think that if you would have a drug like an antagonist to start with, nobody would have never made an agonist, but that's life. So there is an antagonist on the market, the GnRH. It's been there like for probably 5-6 years. And we have accumulated evidence that there may be some interest using the antagonist. It's a rapid onset of action. It seems to be a little bit better on patients who have a lot of urinary symptoms. It seems to be a link with cardiovascular risk associated with androgen deprivation therapy. But unfortunately, the drugs come with a series of limitations, and the most important being that it's a 1 month painful injection. And it may be one of the reasons why it's not really used. I think that it's roughly represent 10% of the. I know yesterday Neil Shaw showed an oral antagonist, which if you look at the pharmacology and the initial PSA data, it resembles the efficacy of the GnRH, but seems to overcome the main limitation. So I would say when I review the abstract and the data, I also look at the other trial they've made. It looked very promising. However, it's an oral drug. And the goal of this drug is to lower testosterone. So we really have to wait to see what is the long-term adherence. Because as for any oral drug, we know that patients are never as adherent we believe they are. And so they still have to pass the hurdle of doing a 1-year trial. But I think that if they do so, still maintaining testosterone, that's going to be a very big player, and we should keep an eye on that drug.
So in a sense, it's a double-edged sword, isn't it? One is dealing with compliance of the patients. Will they take a daily tablet? And what happens if they miss 1 or 2 or 3 or 5 days treatment? Again, something which is a depot. I think that's a question to be answered. One of the important bits of data for me from that presentation was the recovery of testosterone once the drug was stopped.
So yes, clearly that is, let's say tomorrow you have the drug, okay? You wouldn't probably use it in upfront metastatic patient that probably in the future will receive other drug, abiraterone, enzalutamide. So we don't want to multiply the pill in these patients. So if tomorrow you tell me that drug is available, I see it in patients treated with short course hormone therapy, adjuvant radiotherapy. And in these patients, we know many of them, especially those aged 75 or more, they have difficulties recovering from that LHRH agonist or antagonist suppression. So they're adding another potential advantage in a specific group of patients, which are those you want to give 6 months, 1 year, and no more. And indeed, he showed very promising data about LH and LH recovery. So once again, I mean, very nice, very anxious to see what it's going to give in 2-3 years.
And this cardiovascular risk profile, is that going to have any legs?
First of all, we have to confirm the data, the initial data. But with the GnRH, I was an author of this. We have clearly specified in the paper that actually these are observations from randomized trial, but this need to be confirmed. So I've tried to see whether the company would invest upfront in a clinical trial in patients with high-risk cardiovascular disease, because if I was them, I would say that's maybe another niche to look at, because this is really something we would like to have a definitive answer.
There was another paper in the same session, which I thought was a fascinating paper. And this relates to the neoadjuvant approaches to surgery. In other words, using anti-androgenic approaches, either with monotherapy or with combined therapy, alongside prostatectomy, in a very sophisticated study involving high-quality translational science with molecular biology associated with the analysis. This was Bruce Montgomery and the DREAM team.
Yeah.
Tell us a little bit about that.
So I call that the scary paper, okay? Because I think as urologists, we have quite an unlimited faith in hormone therapy, okay? And very interestingly, you know that very well, we have conducted many trials with neoadjuvant maybe 10 years ago, and we always failed to demonstrate that it translates into a major overall survival benefit. No, before going to that trial, we also have to put in perspective the result of Stampede, the result of the early docetaxel trial, who seems to indicate an additional benefit. So why is it the scary paper? Because you take patient, high-risk localized disease, the standard where we don't know really what to do. And I do remind to people that at this point in time, everybody's kind of interested in the upfront metastatic, because they pick up a lot of attention with Stampede and all, but in most of European countries, like Belgium, for instance, 60% of the patients who die from prostate cancer, they enter the disease as high-risk localized disease. And we haven't done much for these patients, especially, except showing that we can do radiation therapy or remove the prostate. That's very interesting. So what they do basically, they take what is probably the best hormonal combination. They take leuprolide, they add dutasteride, and they add enzalutamide. So you really have your dream triplet. You take probably the 3 most efficient drugs, and you give that for 6 months to the patient. You look from outside, like we do all the time, you look at PSA, beautiful, 100 PSA response. You remove the prostate, you give it to the pathologist, and then the guy answers, you know, in only 15% of the case, I don't see any more cancer. So you say, what? Your pathologist is telling you that you give 6 months of the most efficient treatment, and basically you eradicate 15% of the cancer. And that raises a lot of questions. And the most important is, what is the significance of this remaining cancer? Is it dormant? Is it active? Has it been sent back to a kind of primitive pre-AR state? Nobody knows. But to me, at least, it means 2 things. We can be right or wrong. We can say they're dormant and we should do nothing, or we're going to have to do something more. And that something more, you don't have a lot of choice. You can do surgery, radiotherapy, but also it's a beautiful underlying explanation for why there might be a benefit of adding docetaxel to these patients. So from the paper I review, this one was really the one that raised a lot of very interesting questions.
So really what we're saying is that hormone therapies on their own as neoadjuvant are really not going to be sufficient. We are going to have some form of ablative therapy alongside that, whether that's radiotherapy, surgery, or some other form of chemo-based treatment if we're going to destroy these cancers.
Yeah, unless we really demonstrate that what we see is dormant cell, we're going to need to do something. And this is not a risk I would take, no, in light of the Stampede result.
Well, that brings us nicely to the Stampede study and this notion of supplementary therapy right at the outset of standard androgen deprivation. And the Stampede study, which is a study close to our hearts, I've been closely involved with the development and the running of Stampede. And Bertrand, you've been a key member of the Independent Data Monitoring Committee. That means you do a lot of work and get very little of the credit. But this is starting to yield results. And importantly, it is helping to change practice around the world. What the Stampede data has shown, this was presented at ASCO in 2015, has been recapitulated here and is about to be published with a manuscript going shortly to one of the major journals. It's shown that in high-risk localized disease and patients with metastatic disease at first presentation, the addition of cytotoxic chemotherapy with docetaxel results in a major survival advantage. This was about 11 months overall, but when we looked at the metastatic patients, the overall survival advantage is in the region of 22 months, which is really a major advance. And what this has done is supplemented data which came from the Charted study, presented originally a year in advance at the ASCO meeting, and it has settled some of the uncertainties in relation to the conflicting data between GnRH 15, the French study, which didn't show an advantage with chemotherapy in that setting, and the Charted study. So we now have very clear evidence, and this has been substantiated by the meta-analysis done by the StopCap team, which is based in London through the MRC, taking data from Charted, from GnRH 15, and from Stampede, showing conclusively that there is a survival advantage to docetaxel up front. So Bertrand, this is a game changer, isn't it, I think? And as a urologist, is this going to affect how you practice in Belgium?
I mean, in Belgium, yes, for the simple reason that we have a fully integrated MDT system. And I mean, we must say that following Charted, it changes already. Don't forget also, it's something important, docetaxel is now a cheap generic. And if you explain to patient, it's obvious. I mean, when you say, it is funny that as a urologist, you do radical prostatectomy to men with intermediate risk disease, with uncertainty about the overall survival benefit, and you would deny a treatment like this. No, having said that, as you know, we both traveling a lot, and I'm quite scared about the many reasons that are given to delay that treatment. But I think it is to me, it is not science anymore. I tell my fellow urologists, it is a matter of corporate responsibility. You want to be uro-oncologist, you must now embark on the principle of oncology. And when you have a study like this, it is not whether you believe or not, or you say the result can be tricked anymore. No, you have to sit with your colleague and say, how do we do that? And how do we transform that study into a reality for all the patients diagnosed at that stage of the disease?
For me, it is in a way rather like breast cancer was many years ago, managed by surgeons and not in a multidisciplinary way. And now breast cancer is a multidisciplinary disease. And urologists have to move along these lines, surely.
And it doesn't say that as a urologist, you're not going to be involved. You're going to be involved more. But it is about redesigning our position in this. It's time to think what is going to be the role of the urologist in the future. It is going to be a great role, but it's not going to be the same role.
So it's clear that there's interesting data emerging, some of it groundbreaking, practice changing, and that has implications for urologists, surgeons, and also for non-surgeons, radiotherapists, medical oncologists, and all of the people who work alongside them. This is something which urologists are going to have to embrace, and I'm sure in time all urologists will follow this path. We have a lot of exciting data coming out, we've more to follow, and I hope that we've given you an insight into a couple of new things which have been reported at this important meeting. Thank you very much.